Hello and welcome to the highlights from the American Diabetes Association Congress 2023. I'm delighted to introduce you Dr. Fraser Gibbs. Fraser is a consultant in endocrinology and diabetes at the Royal Infirmary of Edinburgh and honorary clinical reader at the University of Edinburgh. Fraser attended and presented at the 83rd American Diabetes Association Congress in sunny San Diego in June. And he's going to share with you today some of the highlights from the ADA Congress. Thank you very much, Fraser, for giving your time, and over to you.
Thank you very much, Nikki. So these, first of all, are my disclosures. And these are very much my highlights, so please don't be offended if any of your own research is there or if I don't cover something that you're specifically interested in. But I was just trying to tie together a few themes that are largely relevant to type 1 diabetes, but actually I'm starting off here because it was hard to ignore it, to be honest, that the ADA 2023 was really the year of the weight loss blockbuster drugs being presented at the conference. But I think there is potentially tangentially a link between obesity and type 1 diabetes, and that's because actually in many ways this is a major issue affecting people with type 1 diabetes that we maybe don't focus on a great deal. And to give some context there, this is data from my own clinic where the median BMI of people with type 1 diabetes, adults with type 1 diabetes, is 26.3 kilograms per meter square. And 25% are obese. And you'll see from the histogram, which is organised by whether people have met the HbA1c target of less than 58 millimoles per mole, that as you move beyond that, the blue bar there into the obesity range, there is a reduced frequency of meeting that target in people who are obese. And in fact, we published a paper a few years back in Diabetic Medicine where this was really just one small part of it, looking at predictors of glycemic control in type 1 diabetes. But actually, independently of other parameters, there was a 35% lower likelihood of meeting the 58 millimole per mole target if you were obese. So I would suggest that this is a big issue. Now, of course, that's not to say that treating obesity and making people normal weight would result in improved glycemic control. That's a bit of a leap, of course, but certainly it's something worth exploring. And of course, there are many other reasons to do that. So I was just going to go through some of the big studies that were presented and then published concurrently in the major medical journals. And the first one here, oral semaglutide in type 2 diabetes. I should say that the studies that are highlighted in pink are not in people with diabetes, but in people with overweight and obesity. And so the semaglutide 50 milligram oral dose resulted in an average of 8 kilograms of weight loss, 68-week follow-up study, people with type 2 diabetes on 1 to 3 oral agents, and a baseline weight of 96 kilograms, HbA1c reduction of 22, and nausea rates of about 27% and vomiting rates of about 18%. So for each of these studies, I've presented similar data here. I think that there are obviously other important features of the studies, but these are, I think, quite important parameters to consider. The next one is another oral GLP receptor agonist, is orforglipron, 45 milligram oral dose, and that resulted in 10 kilograms of weight loss on average. A shorter study, smaller numbers, and people in this study were on metformin or diet alone, and baseline weight had a little higher than the Pioneer Plus study at 100 kilograms, very similar reductions in HbA1c, and fairly similar rates of nausea and vomiting as major side effects. And then you've got the same drug here, but in this situation, in people without diabetes, a study of 272 people with 15 kilogram weight loss. And of course, you'll be aware that typically these weight loss drugs do appear to achieve better weight loss in people who don't have diabetes. And the baseline weight in this study was significantly higher than the baseline weight in the two studies presented beside it here. HbA1c reduction in this study wasn't assessed. These people didn't have diabetes, and you'll see that the rates of nausea and vomiting were a little higher perhaps than in the other two. So then moving on, we've already seen studies previously presented in tirzepatide, but here's another one, the SURMOUNT-2 study, 15 kilogram weight loss in people with type 2 diabetes on oral hypoglycemic agents, and 72 weeks follow-up here, baseline weight of 101 kilograms, and similar to the studies I've mentioned on the previous slide, 23 millimole per mole weight loss, HbA1c reduction, sorry. And you'll see that that's quite consistent across a lot of these weight loss studies in type 2 diabetes, 20% nausea, 11% vomiting. And then we move on to a smaller study, but this one using cagrilintide and semaglutide. So this is one of the amylin analogues, which have a little more traction, I think, in US diabetes than they've ever had in the UK. But this is a combination treatment with the GLP-1 and this novel agent, and that resulted in type 2 diabetes and 16 kilograms of weight loss. As I say, smaller numbers here, 32-week follow-up, and people who were on metformin and may also have been on an SGLT inhibitor. Baseline weight quite high in this study, 106 kilograms, and kind of, again, similar rates of nausea, maybe a lower rate of vomiting than some of the studies in the previous slide. Then moving on to that oral dose of semaglutide that has been studied in type 2 diabetes as well, but this is a study in people who did not have type 2 diabetes, 16 kilograms of weight loss. They did actually measure HbA1c reduction here, and it went down by a very small 2 millimoles per mole. Quite high rates of nausea and vomiting in that study in people with obesity or overweight, but not with type 2. And then finally, this triple agonist retatrutide, which is a GLP-1, GIP, and glucagon agonist, and study on the left-hand side from the Lancet in people with type 2 diabetes, 36 weeks follow-up. They were either on diet alone or metformin, baseline weight of 98, and HbA1c reduction. Again, that kind of very consistent number of about 22 millimoles per mole, 20% nausea, 11% vomiting. But I think it's fair to say with all of these studies, the rates of side effects were not so high that they resulted in discontinuation in high numbers of people. And then I guess really the most impressive of them all is this agent in those without diabetes. Oh, sorry, moving on too quickly there. With 26 kilograms of weight loss on average, and from a baseline of 107 kilograms, quite high rates of nausea, 19% vomiting, but really starting to see weight loss figures that are almost in the sphere of weight reduction surgery when it comes to this particular agent. So, as I say, not directly relevant to type 1 diabetes at the moment, but I think it's very much something that we will look to consider going forward. And I think it's something that I speak for myself here in my own centre, we feel we've maybe underserved people with obesity, with type 1 diabetes. There are studies, and this is a review article from Lancet D&E from a couple of years ago, which have looked at liraglutide in the context of type 1 diabetes specifically, and you do see weight loss, the highest dose there, 4 kilograms, 5 kilograms, some modest reduction in HbA1c, but maybe not to a level that's clinically relevant, and reduction in insulin dose, but the payoff there is an increase in symptomatic hypoglycemic events. So I guess arguing here, not necessarily a drug to be initiated to improve glycemic control substantially, but perhaps with these combination agents going forward, studies to improve obesity and help people lose weight. And then I'll move on again to another drug that we're not really using, certainly in Scotland in type 1 diabetes, and clearly the licensing issues around SGLT in type 1 have changed over the last few years, but is safe use possible? And I guess one of the issues here is that there are so many benefits of these drugs that we're seeing in people with heart failure, with renal failure, that it would be nice to have a framework where perhaps they could be used safely. And you'll be aware, I'm sure, of the studies that have been done in type 1 diabetes, looking at a range of different SGLTs with reduction in weight, some effect on HbA1c, which approaches clinically meaningful levels, reductions in insulin dose. But of course, the elephant in the room was the fact that even in the closely controlled environment of a clinical study, you were seeing quite high rates of diabetic ketoacidosis. And indeed, a review article from around 4 years ago noted that if you extrapolate out from some of these studies, then you may be looking at 16 additional deaths per year per 100,000 patients in those with type 1 diabetes on these agents. And also making the point that although in the initial phase of treatment you see quite significant reduction in HbA1c, that effect does tend to wane over time in these clinical studies, despite maintaining weight loss. So we're not quite there yet. But this study, and just for information, when I'm referring to studies that were presented at the conference from now on, I'll give you the session name and generally the speaker in the session as well at the bottom of the slide. So this is a study which looked at the EASE program of SGLT therapy in type 1 diabetes, and was looking at the effect of predicting DKA based on ketone monitoring, so finger prick ketone monitoring. You'll see here that people who had a DKA event were more likely to be female, more likely to have lower weight, more likely to be on pumps than MDI, but no difference in HbA1c between the groups with and without events, and were more likely to have checked ketones more often if they had an event. And they created these ROC curves looking at maximum ketones, mean ketones, last ketone measurement to see how effectively they predicted DKA or severe ketosis. And to move on to the next slide here, using a cutoff of 0.7 for maximum ketone, that was the optimal outcome in terms of achieving the best sensitivity and specificity. If you used a threshold of 0.9, then you were a bit more specific with that, and you're seeing likelihood ratios of 2.7 or 3.7 in terms of the prediction of DKA. So a suggestion here that the capillary ketone measurements could be helpful in identifying those at risk. And using a threshold of greater than 0.9, as I say, had this likelihood ratio of 3.7. They also had another study that they presented in poster form, and this looked at the placebo-treated people in the EASE program. Smaller numbers of events here and fewer numbers in terms of the participants allocated to placebo, but essentially looking at the same sort of thing, the 6 to 12 month occurrence of DKA, and assessing maximum and mean ketone levels a couple of times each week as per the protocol in the study. And here there was a likelihood ratio of 2.9 when ketones were greater than or equal to 0.8. So just holding out the possibility that ketone monitoring might be one way of reducing some of the risk here. And as I mentioned at the beginning, I think so much to be gained potentially from developing more evidence in the type 2 population when it comes to CKD and heart failure particularly. And it doesn't seem likely that we're going to see large scale studies specifically in that population. So we are probably going to have to extrapolate out from other work. And there was nothing, as far as I could see this year at the ADA, presented on interstitial ketone monitoring, but it really does seem to me a potential use of this emerging technology, that if you had concurrent glucose and ketone interstitial monitoring, then that you potentially could be introducing SGLT inhibitors in the type 1 population with a bit more confidence in terms of the safety. So it'd be nice to see how that develops. And again, another study which on the face of it, another couple of studies on the face of it are type 2 diabetes. There have been type 1 studies conducted on weekly basal insulins. To my knowledge, I don't think they've been published yet, but I could be wrong about that. Happy to be corrected. But it does seem to me that these insulins have a very specific indication potentially in type 1 diabetes, which would be in people who are at risk of recurrent DKA, where they could be administered on a weekly basis in an observed way. or potentially also in people who were worried about starting on closed loop because of the lack of basal insulin, where again, a once weekly low dose of basal insulin would perhaps reassure us in terms of DKA risk. So what did the two type 2 studies presented at the ADA show us? We had Onwards 1, which was comparing icodec weekly versus glargine U100, and then Onwards 3, which was icodec versus degludec. And quite similar results, to be honest. The HbA1c reduction in this treat to target study was minus 0.2 for both studies. Bear in mind, you don't really expect to see a massive difference in HbA1c in treat to target studies. The Onwards 1 study had bigger numbers, longer follow-up, 78 weeks versus 28 weeks. The mix of individuals who were all insulin naive at randomization is quite similar in terms of their baseline treatment. And I think, with the exception maybe of fairly low rates of GLP-1 receptor agonists compared to maybe what we would see in our practice up here, fairly close, I think, to what you would see in practice. And the baseline characteristics, again, quite standard, I think, for a type 2 study, and treating to target 4.4 to 7.2 millimolar, starting with 10 units of glargine or 10 units of degludec and 70 units of icodec, and then titrating. And what the Onward 1 study showed was this very slight superiority in terms of HbA1c and a 4.3% increase in time in range. Onwards 3, superior HbA1c, fasting plasma glucose wasn't different. But in both studies, a rate ratio which was elevated for level 2 and level 3 hypoglycemia, although I think it's worth saying, and the authors of both studies point this out, that the actual rates of those types of hypoglycemic events were very low. So Onward 1, just showing the time course of HbA1c reduction on the left-hand side. And then at the end of the study proper, rather than the extension phase, time in range of 71.9 compared to 66.9, with just slightly increased, but still pretty low levels of hypoglycemia. And then Onwards 3, again, time course here, looking at differences in HbA1c between icodec and degludec, and icodec having slightly lower HbA1c by the end of the 26 weeks. But the rates here with icodec of combined level 2 and level 3 hypoglycemic events at 26 weeks, 0.35 per patient year of exposure, and 0.12 with degludec. So significant, but as I say, and as the authors presented, quite low rates overall. So I think in terms of these weekly insulins as well, if you consider the maybe niche groups that we'd be considering using them in type 1 diabetes, we'd perhaps not be aiming to treat to quite so tight targets in those types of individuals, perhaps with recurrent DKA or poor adherence to insulin therapy. So perhaps some of those risks of hypoglycemia would be less, but I guess that's speculation, and there will be studies done in due course to confirm that one way or another. So to shift, I think, fully to type 1 diabetes now, next theme I was going to cover is C-peptide preservation, new approaches to that, and also what the clinical relevance might be. And I'm taking this here from one of the symposia at the conference, which was major advances and discoveries in the preceding year. And if you're eagle-eyed, then you'd notice that actually the paper that's been presented here on teplizumab is not something from 2022 or 2023. But what has changed in the last year is that the FDA has approved this drug, this anti-CD3 antibody, for people at risk of type 1 diabetes, and specifically the study and the authorization here was relatives of people with type 1 diabetes with stage 2 diabetes in terms of positive antibodies and dysglycemia. So these are people who are fairly far down the path towards type 1 diabetes, as opposed to other populations at risk, people who are high genetic risk, people who have positive antibodies but normal glycemia. So a very specific cohort, but the study itself showed this hazard ratio of 0.41, clear separation between placebo and teplizumab. And so quite exciting, I think, in terms of being the first step towards type 1 diabetes prevention. And obviously we'd expect in the coming years for this to get European authorization. An alternative pathway to delaying C-peptide decline is verapamil. And I mean, this seems extremely odd. Obviously, verapamil for most of us is a drug that we hardly ever use anymore. It was used primarily in the past as a rate-limiting calcium channel blocker, but it works by blocking the thyroidoxin interacting protein and therefore reduces beta cell apoptosis. So that's the mechanism here. And this study from JAMA earlier on in the year in children at the onset of type 1 diabetes, so randomized in this study 24 days from diagnosis to either verapamil or placebo, and looking at the C-peptide area under the curve after a mixed meal tolerance test, showed that there was a significant difference in C-peptide, so 0.65 in the verapamil group at 52 weeks compared to 0.44 in the placebo, and that was statistically significant. And you often expect in adult onset type 1 diabetes for the autoimmune process to maybe be not quite as florid as it is in pediatric disease. So it does leave it open that this may be an even more effective intervention in adult onset type 1. But there is a study currently recruiting to address that particular question. And I think that even when you move away from preventing the onset of type 1 diabetes, I think there are potentially strong arguments for preserving even minimal C-peptide positivity. And I'm going to be self-referential here, as I might be a few times through this talk, just in terms of a study that we produced a few years back, which looked at C-peptide levels in people with type 1 diabetes, either less than 10 or between 10 and 200, and showed that you had significantly better glycemic variability, significantly lower time below range if you had even fairly modest C-peptide positivity. And other data from Scotland from the type 1 bioresource study have shown that across a wide range of C-peptide levels, you have these associations with insulin dose, HbA1c, most impressively with presentation with severe hypoglycemia, but also things like risk of developing retinopathy. So being able to preserve C-peptide even at a level of 50 picomolar or 20 picomolar is potentially very clinically important in terms of reducing hypoglycemia risk and complication risk. So one of the studies at ADA which looked at this is one that was presented by someone from Amsterdam University. This is a cohort of 489 people with type 1 diabetes, adults, and they used urinary C-peptide in 4 categories: undetectable, low, intermediate, or high. Duration of diabetes obviously was shorter in people with high and intermediate compared to those with undetectable. And what you see here is whether it's time in range, where undetectable, lower time in range, higher time in range with this gradient across, time below range, time above range, all looking to support the idea that residual C-peptide across varying levels is important. That's CV for glucose, HbA1c, and insulin dose per day. So lots of different parameters and positive results across the ranges there. And when they looked at multivariate analysis, you'll see that even when you adjust for sex, age, duration, insulin dose, and type of insulin, you have these positive results in terms of predicting time in range and low glucose parameters as well. So I think that hopefully makes a strong case for the importance of C-peptide preservation. I think there's really exciting times ahead, a lot of work being done in the UK. And I know that Parth Narendran in Birmingham is leading work on diabetes prevention and looking at future immunotherapy trials there. So widening options in terms of intervention, lots of studies needing done to determine the optimal regimens, strangely repurposing old drugs for new effects. And I think probably within the next decade, real implications for screening programs, firstly in people with first-degree relatives with diabetes, but then laterally, potentially even national screening programs in kids to help prevent type 1 diabetes. So really exciting times for pediatric diabetes. And potentially this role in C-peptide preservation, even in people who are newly diagnosed, and perhaps we in Scotland have a C-peptide screening program in people with a clinical diagnosis of type 1 diabetes. So this idea that potentially we might pick out people who've had diabetes for a long time, but if they have C-peptide, then maybe approaches to ensure that that's preserved to improve their glycemic control, reduce hypo risk, and to be able to start to combine the massive advances in technology with these massive advances in biologic therapy. So I'll move from that to looking now at CGM metrics and comparing that with HbA1c. Again, apologies that I'll start with some work that we've done in Edinburgh, but I think it helps set the scene a little bit and maybe shows some of the controversy in terms of conflict with results of other studies. So in this study that we published last year, we were looking at the difference at a moment in time between the estimated A1C from Libre and the actual HbA1c recorded in the clinic. And just to go through the various panels here, what we found was the actual HbA1c was higher than the estimated HbA1c at the low end of the HbA1c scale, and the opposite was true at the high end. So actual HbA1c was lower than the estimated HbA1c at the high end. We found that actual HbA1c was lower than the estimated HbA1c in younger people, but that the actual HbA1c was higher than the estimated HbA1c in older people. So in an older person, you might see a higher HbA1c for exactly the same average glucose as a younger person. And then similarly, actual HbA1c is higher in women than for men for the same estimated HbA1c. And that's potentially important because there are a lot of the epidemiological studies that suggest men meet thresholds for glycemic control more than women do. And part of that may just simply be that if you have a yes/no threshold for control and a very slight difference in how HbA1c reflects glycemia, then you're going to shift quite a lot of people from one category into the other. The other thing that we looked at was the snapshot prevalence of retinopathy. And what we found was that retinopathy prevalence was lower in people who had higher actual HbA1c compared to where the estimated A1c was higher. So this idea of people being high glycators is not supported by that. That actually, if you were a high glycator, you were less likely to have retinopathy. And when we looked at the logistic regression analysis for that, the odds ratio was 0.55, independent of other predictors. So although it's just a moment in time, it's not prospective. The idea there was that potentially that this concept of being a high glycator, certainly as indicated by HbA1c, maybe was not something that has a major impact on complication risk. So a couple of interesting studies from the ADA. This one is not type 1 diabetes actually, but it's looking at genetic variants which are independent of glucose variation that modify your HbA1c. So there are erythrocytic variants that were looked at. There were other genetic variants that were independent of the erythrocyte. And they created categories, so lower HbA1c, higher HbA1c, and then a category in the middle. And what you'll see is that this is looking at retinopathy prevalence on the y-axis, European ancestry and African ancestry, and this idea that people who, for non-glycemic reasons, had a lower HbA1c were actually more likely to have retinopathy than people who would have been high glycators. And the next slide here looks at that in the two different cohorts across the glycemic range in terms of HbA1c, and again showing that there's a significantly increased risk of retinopathy in those low glycators, and you'll see the same in the panel below as well. So another study suggesting that potentially the sort of concept of being a high glycator maybe not linked, and in fact what might be happening here is that you delay intensification of treatment, or you delay diagnosis of diabetes in people who have that high risk of low HbA1c, and so actually it's a function of under treatment rather than anything else that you have a higher risk of retinopathy. So to move on to another study, this time mostly in type 1 diabetes. This is a study kind of similar to the one I presented at the start that we published. They used a slightly different metric. They used GMI, and what they did was a ratio of GMI to A1C to define two groups. The glycation ratio of less than 0.9, it's kind of high glycators, and glycation ratio greater than 0.9. So if you had this low glycation ratio, then you had more hemoglobin glycation. And you'll see here they included about 660 people, mostly type 1 diabetes, and about 16% of them had this so-called positive discordance, this high glycation. What you'll see is that the high glycators had a much higher HbA1c, 8.4 compared to 7.1. The GMI was higher in this, it was lower in this group at 6.8 compared to 7.3, but you know, the magnitude of difference is greater in terms of the actual HbA1c than the GMI. I think that's potentially a problem with the interpretation. In terms of what predicted belonging to that group, age wasn't a predictor, anemia was on the borderline statistically speaking, CKD was more likely to associate with high glycation status, and diabetes duration was not. And what they suggest here is that those people with high glycation were around twofold more likely to have retinopathy. And if you limited that to the subgroup with normal hemoglobin, it was closer to a threefold increased risk. One thing I'd point out is that in terms of the categorization of people in respect to their glycation ratio, it's quite striking that it's very similar in terms of Dexcom G5. There seems to be a mismatch with Libre and then small numbers, but an even bigger mismatch with Dexcom G6. So it does suggest that maybe there are device-specific issues here. And like I say, I'm skeptical just in terms of the fact that to belong to that high glycator group, you already had quite a high HbA1c to begin with. So I'm not sure how much further forward this takes us. I think what's going to be really nice to do is look prospectively in this era of widespread CGM use at whether, independent of glucose exposure, there is some link between glycation status and the subsequent onset of complications. So move on to a session which was really just a celebration of the DCCT, which I think is still one of the best studies ever conducted in clinical medicine. And of course, we'll all be familiar with this idea of metabolic memory, just this phenomenal preservation of the benefits of that 6 or 7 year period of improved glycemic control in the early 1980s, translating out to studies in 2014, 2010, that you still have this dramatic risk reduction when it comes to retinopathy, kidney disease, and neuropathy. I mean, it really is incredible. But what they also introduced at this meeting, which I hadn't seen them do before, was also the concept of metabolic amnesia. So you do see that from the close of DCCT to the early EDIC follow-up studies to the later EDIC follow-up studies, that you do over time, and I think not unexpectedly, see that the benefit, the magnitude of the risk reduction does fall over time. But of course, you're still seeing fairly major risk reduction, even 20, 30, up to sometimes even 40 years from the original intervention. And DCCT is a study and a cohort that are still delivering in terms of important advances in diabetes care. So this is a study from a few years back where, using that cohort, they were able to suggest individualized screening frequency with respect to retinopathy. And I think similar things are happening all over the world. And I know in Scotland, the SDRN epidemiology cohort was used to individualize our screening pathways over the last few years. But what this study has become now is really an excellent cohort for examining the impact of diabetes on aging in a way that really hasn't been possible before. This is now a much older cohort, people who've had diabetes for a very long period of time. And you just get a feel that the session itself covered a lot of the different elements of DCCT, but so many things that they're continuing to look at: chiararthropathy, neurocognitive changes over time, and how that relates to hypoglycemia and HbA1c, even more niche things like bladder health and skeletal health and muscle loss. So much more to come from this study, despite the fact that it's now over 40 years old. So another topic, another area that I think is potentially quite important: glucagon, which preparation to use, who needs it. And there have been a couple of guidelines recently. The Endocrine Society, American Endocrine Society, have also recently published guidelines. And broadly speaking, I find it hard to see who wouldn't fall into a category where having a glucagon pen or whatever preparation you favour would be recommended, because ADA, you're saying that glucagon should be prescribed for all individuals at increased risk of level 2 or 3 hypoglycemia, which I think at certain times is likely to be most, if not all, people with type 1 diabetes. And in this session, the argument was made that the kind of conventional reconstituted glucagon preparation is tricky to use, particularly in the heat of a stressful moment, like a friend or relative having a severe hypo. So there are these new formulations, nasal glucagon, dasiglucagon. I should say that, as far as I'm aware, neither of these are available in the United Kingdom. But studies presented showing that in simulated severe hypo situations, that you get fewer failed deliveries and quicker delivery of the treatment. And as well as the conventional glucagon, you've got nasal glucagon, non-aqueous glucagon in pens, and then dasiglucagon, another a glucagon analog there. This study was published earlier this year, and showing that in America, in this cohort, only about 17% of people with type 1 diabetes actually had a fill of a glucagon prescription, and that there are ethnic differences, there are gender differences in terms of fewer men picking up prescriptions, and also socioeconomic differences favouring people who are more wealthy, that don't seem to have changed massively over time. And again, just to shamelessly draw in some work that we've done, and actually just got published last week. If you want to have a look at it, we looked at everyone in Lothian, which is about 5,000 people with type 1 diabetes in the adult population, and about 3/4 of them had not collected a glucagon prescription since 2019. And when you consider the shelf life of glucagon, that means that about 3/4 of people don't have an active glucagon pen at home. And a small but significant proportion of people have extremely high use of glucagon. And we looked at that very high use group as potentially being a marker of severe hypoglycemia, somewhere between self-reported hypoglycemia, which is often underreported because of concerns about driving a license, and then severe hospitalized hypoglycemia, which really is just the tip of the iceberg in terms of severe hypo. So anyway, 34% of people who'd been hospitalized with hypoglycemia had collected a prescription for glucagon, but I'd suggest that's still incredibly low. More than about two-thirds of people who'd had a severe hypo still don't have a glucagon kit at home. And that compares to 25% of people who had not had a severe hypo. It would be pretty expensive to give everyone the cheaper glucagon kits, but it would be even more expensive to give people the available reconstituted glucagon kit in the UK. And what we found was that to have ever collected glucagon, you were more likely to be female, to have longer diabetes duration, to have impaired awareness, but still minority of people with impaired awareness collecting glucagon kit, and also people who use technology such as pumps or CGM. The people who were using a lot of glucagon, and the highest number of uses over that 3-year period, was someone who'd collected over 100 glucagon kits. Is longer diabetes duration, socioeconomic deprivation, and high glucose variability on CGM. So those are things I think to look out for. It would be quite a nice piece of information to have when you see someone in a consultation, just to know how many glucagon kits they'd collected. But do look out for people with very high glucose variability as a potential risk factor for severe hypoglycemia. So lots of potential widening uses. I mean, this is all very speculative, and given how expensive these kits are, the idea of people microdosing glucagon instead of using carbohydrate in the context of exercise and things like that, I think is quite fanciful at the moment. But of course, we know that there are potentially these dual hormone closed loop systems in the offing as well. And to quickly move to closed loop, this is a Canadian study, observational study, which looked at adults with type 1 diabetes, and using blinded CGM over a 4-week period, compared people who were on DIY closed loop versus commercial systems. And I should say the commercial systems are the Tandem, sorry, I misspelled there, Tandem Control IQ, and the kind of older generation of Medtronic closed loop systems. You'll see that if you're a commercial, a DIY user, tended to be younger, tended to have a higher income. And in terms of clinical parameters, these systems spent more of their time in auto mode, and more of the people using them were using ultra-rapid analogs. There was non-inferiority in terms of the comparison, and indeed the time and range for the DIY systems was numerically higher. And you'll see that presented here in terms of very slightly higher rates of hypoglycemia in the DIY systems, but a higher rate of time in range. And this was a study presented related to Omnipod, and this was just to show, moving to a different study here, that where Insulet had data on people who were using DASH and then converted to Omnipod 5, you see across the age groups, caveat here being that these were people, they selected out people who were using the lowest target on the algorithm. So it's not all comers, but where people were using the lowest target, you were seeing a step up, roughly 10%, depending on the group, in terms of time and range, and also reductions in time below range. And again, that was still limited to those using the lowest target. So just more evidence, as if it were needed, that closed loop systems are effective. This is just a session which summarized some of the kind of practical points that I think maybe some people find quite useful. Basal rates in closed loop systems are obviously still important for times when the systems are not operating in their automated mode. You'll often find people using closed loop systems that their insulin on board is low first thing in the morning. And so people will typically have to be more aggressive with their insulin to carbohydrate ratio. That is, require more insulin to cover breakfast than they may have done when they weren't on closed loop. And for a similar reason, insulin on board is often low prior to hypoglycemia, due to the fact that the systems have been cutting off insulin supply, so it may require less glucose to correct hypos in the context of a closed loop. And for practical points to discuss with users, I think those are quite useful things to focus on. This speaker went through some of the currently available systems. I'm afraid I'm not going to cover CAM-APS, as they didn't include that. It's not available, I believe, in the US at the moment. But T-Slim, like basal automation, adjusts the programmed basal rate to keep things in target. So it uses the programmed basal rate as the jumping off point there. It gives automated corrections, which represent 60% of the correction dose as often as every hour if the predicted glucose is likely to be greater than 10. So again, bear in mind with tandem T-Slim, important to make sure that the user set correction dose is fairly sensible, because that is going to play into how the automation works. And then you've got different standard mode target here of 6.3 to 8.9, and the correction target is fixed at 6.1. And then you've got the opportunity with the exercise mode to increase that to 7.8 to 8.9. Active insulin time and correction target are both fixed in this system. And the speaker in this session felt that T-Slim is a good system for people who maybe bolus less often than ideal. I think Omnipod 5 is probably the system where the feeling is that appropriate bolusing is still probably most important to achieve good outcomes. And it'll be interesting as we gain experience in the UK to see how that pans out. The automated basal is calculated from the total daily insulin and updated with each pod change. There's no bolus automation as such, and you can set the target from 6.1 to 8.3, and the activity feature raises the target to 8.3 and reduces basal delivery. So insulin carb ratio, correction factor, correct above threshold, and active insulin time will all have an impact on the user requested bolus doses. And as said before, bolus timing is important here, as it is with all of them, to be honest. I think that there should really still be a real focus on optimal bolus timing, but there may be a need to alter the insulin to carb ratio to be more aggressive when people start using automated systems. And Medtronic 780G, which a lot of people listening to this, I'm sure, will have a lot of experience with, automated basal delivery every 5 minutes based on the sensor glucose, and automated correction dose if the sensor glucose is predicting greater than 6.7 and the auto-basal is maxed out, which is their so-called meal detection system, which has a target of 6.7. You've got a variety of targets that can be set and a temp target, particularly for exercise, and also safe bolus features, which predict that if it predicts that a bolus is likely to cause a hypo, it'll reduce the amount of insulin delivered. And I think an important practical point for this system is that it works best when the target's set to the lower end, obviously, but also that although active insulin time is called active insulin time here, in reality, that's not really what it is. It's really just a way of making the algorithm more aggressive, and they very strongly recommend setting that to 2 hours active insulin time. People are using 780G. And again, this looks like another good system for people who maybe bolus suboptimally. So I'll maybe skip past I know I'm running out of time here, but I'll skip past maybe the specifics about exercise and simply say that there's a really good review article on automated insulin delivery and exercise. And in fact, this recent issue of Diabetes Spectrum is really themed around exercise and diabetes. So if that's something that interests you, then it's well worth a look at that issue of Diabetes Spectrum, which you can get online. I was going to move on to smart pens now. So I think smart pens are really important because there's a risk of us leaving behind people who like not to use pumps. And I think there are really exciting prospects going forward for real-time dosing advice, reduction in missed doses, that sort of thing. But that's not really what the current generation of smart pens do. But this is a nice observational study using the NovaPen 6. And essentially, they have this cohort of basal bolus users, about 2,500, and of that, around 500 who were known to be type 1. But I think it's fairly safe to assume that the vast majority of people within the whole cohort were type 1 diabetes. It's just that wasn't specified. And what they looked at was missing basal doses. So if there was more than a 40-hour gap between basal doses of insulin, and missed bolus doses, which they have a detection algorithm for, which detected increases in glucose related to what seemed like a meal and whether an appropriate bolus dose had been taken. And the thing that stood out for me in this study and that I found most interesting was the number of people over a 14-day period who appeared to have missed a dose of basal insulin was around about 17%, which seemed very high to me. And about 2% of people within that had missed more than 2 bolus doses, basal doses, sorry, in a 2-week period. So it may be as we get more experience with using these, we're going to get greater insights into missed dose behavior, even with basal doses. And you'll see that there's a relationship between time and range and missed basal dose, so that 1 missed basal dose per 14-day period had a time and range of -3%. So as you multiply that out, people who had missed basal doses on multiple occasions, you know, that relationship between time and range is pretty strong there. Individuals with 1 missed bolus dose in the 14-day period had, for each missed bolus dose, that -1.55% lower time and range. But you can see with the bolus doses, the more bolus doses are missed, very strong relationship with time and range. So again, potentially useful as a way of looking at how many bolus doses are missed, and clearly a very big impact in people with type 1 diabetes. So I'm going to round this off by presenting a kind of potted summary of the study that I presented at the ADA. This was looking at hypo questionnaire data in about 800 people, which is about a third of our clinic. 51 years of age on average, 24-year diabetes duration, fairly even gender mix, and 27% pump use, 43% had an HbA1c of less than 58, and the vast majority were using CGM, mostly Libre 2. Headline findings here are that there was a 5% rate of severe hypoglycemia, 21% had an elevated GOLD score, and 10% had a symptom threshold that was typically less than 3 millimolar. The rates of severe hypoglycemia were 4-fold higher if you had an elevated GOLD score or a low threshold for detecting hypoglycemia. So 12% versus 3%, 16% versus 4%. And almost half of severe hypoglycemia occurred in people who had a normal GOLD score. I will move through this fairly quickly, but just to say that when it comes to impaired awareness of hypoglycemia, depression screen positivity, low C-peptide, older age, and socioeconomic deprivation were all factors that were significantly associated with impaired awareness. The things in red were not associated with impaired awareness in our study. And that's them looking at the association with high GOLD score, where anxiety screen positive, depression screen positive, female sex, and socioeconomic deprivation were associated. And I will click past this to go to severe hypoglycemia. So individuals with severe hypoglycemia were more likely to have a positive depression screen, positive anxiety screen, more likely to have socioeconomic deprivation, were more likely to have time below range and time below 3 that was higher, and were more likely to have higher CV for glucose. And as you see here again, more than a 2-fold higher risk of severe hypoglycemia in people who were anxiety screen positive and depression screen positive. And you'll see here the CGM data, severe hypoglycemia in the orange, more likely to have a higher time below range, more likely to have a higher CV glucose, and more likely to be socioeconomically deprived. And that was true even in the multivariate model. Sorry to rush through all these final slides. I just don't want to keep you all. I'm sure you've got clinics to do in the afternoon. And yeah, so the conclusion here would be that I think it's important that we're proactive in screening for depression and anxiety in our clinics, and just also being mindful of the fact that socioeconomic deprivation is a strong risk factor for impaired awareness and severe hypoglycemia.